One type of surgical intervention is transplantation of the pancreas. This can eliminate acute complications associated with blood glucose control. Even though it is good at controlling short-term complications, long-term complications still arise. The 1-year survival rate is 95%, and 83% of these patients are also free of insulin injections and diet restrictions after 1 year. This high success rate is due to improved surgical technique. There are 3 types of transplantation: pancreas alone, or PTA, pancreas after kidney, or PAK, and simultaneous pancreas and kidney transplant, which is called SPK. Most transplants are from cadavers. The patient's non-functioning pancreas is left in place, and the cadaver pancreas is placed in the pelvis. The patient needs to be on medication and antibiotics to prevent rejection and infection. If rejection occurs, signs and symptoms include tenderness and pain over the graft area, drop in urine amylase, rapid increase in blood glucose level, bloody urine, and an increase in temperature. The most serious complication is leaking and intra-abdominal abscess. It is the healthcare provider's responsibility to monitor these patients very closely. After having this surgery, a patient's quality of life greatly improves. Islet cell transplant eliminates the need for insulin use and protects the body against complications of diabetes. This procedure is not widely used due to limited supply of beta cells available for transplantation. Islet cell transplant cells are taken from a cadaver and injected into the portal vein. The transplant cells lodge into the liver and begin to function by secreting insulin. Blood glucose control is near perfect. This procedure works well with type 1 diabetes. Short-term outcome is very good. However, the procedure is only effective for about 4 years before there is a progressive loss of islet cell function. The reason for this is unknown, and that is why this is considered an experimental process.
Diet planning is important in effective self-management of diabetes. The diet should take into consideration the patient's cultural background, financial status, and lifestyle. Some desired outcomes of nutritional therapy are achieving and maintaining safe blood glucose levels, achieving and maintaining a blood lipid profile that decreases the risk for vascular disease, achieving normal blood pressures, slowing the development of the disease, meeting nutritional needs, and providing self-management training. The diet is specialized to that specific patient depending on their usual daily intake, their weight, and lipid and glucose patterns. 45 to 65% of calories a day should be from carbohydrates, such as fruits, veggies, whole grains, legumes, and low-fat milk. Protein intake is suggested to be 15% to 20% of total daily calories. Reducing protein intake to 10% of daily calories may slow progression of kidney failure. When addressing fat intake, fatty acids, trans fatty acids, and cholesterol should be limited to reduce the risk for cardiovascular disease. Saturated fatty intake should be less than 7% of total daily calories. Cholesterol should be limited to less than 200 milligrams a day. Trans fatty acids increase LDLs and decrease HDLs, increasing the risk for cardiovascular disease. These fatty acids are found in foods such as hard margarine and commercially fried foods. Fiber improves carb metabolism and lowers cholesterol levels. The American Heart Association recommends a daily fiber intake of 25 grams. Foods high in fiber are legumes, fiber-rich cereals, fruits, veggies, and whole grains. Fluid intake should also be increased with fiber intake. The blood glucose levels need to be closely monitored because hypoglycemia can result when fiber intake increases drastically. Blood glucose levels are also affected by alcohol. 2 beverages a day for men and 1 for women can be safely ingested with meals in order to help prevent alcohol-induced hypoglycemia. Alcohol raises plasma triglycerides, so it should be avoided by patients with hyperlipidemia.